You can share after 15 seconds.
Okay, no problem.
Madam, you can share now.
So this is our today's speaker, Dr. Zina Makhija. I think she is one of the youngest and smartest cardiac surgeon. And of course, I think she is a dominant female cardiac surgeon. Her academic rank now is she is the senior consultant cardiothoracic surgeon in Care Hospital Group, Hyderabad, India. She does not involve only with the cardiac surgery, but also with the thoracic surgery. And nowadays she is doing a lot of thoracic surgery also. Her educational background, you can see here, she passed her MBBS in 2001 from Lady Hardinge Medical College. And then she took her general surgery training from Maulana Azad Medical College. And then she became member of the Royal College of Surgeons of Edinburgh in 2006, as well as fellow of the Royal College of Surgeons of Glasgow. And then in 2009 to 12, she did fellowship in cardiothoracic surgery from Mayo Clinic, Rochester. And you know, Mayo Clinic is a dream place of training for every cardiac surgeon. He had so many certifications and then awards and honors. For the award and honors in 2015, she got first prize for the best paper in congenital cardiac surgery. Then in 2012, she was nominated for the Young Investigation Award in Pediatric Cardiac Society of India. And in 2011, she got another award. Her published article, so many articles published, and also she had many oral presentations. So article number is 28 and poster presentation is 14. And she is associated with charity activities with the Healing Little Hearts, actively involved with treatment of the Afghan poor patient, and involved in operating Indian children under low-cost government scheme. And in Bangladesh, she also visited, and we are also trying to involve her in our congenital cardiac surgery domain, because she is very expert not only in grown-up child, but also in the neonates and young infants, surgery of neonates and young infants. She has membership from many associations of her own country and also from the Minnesota Medical Association of USA and Royal College of Surgeons of Edinburgh. Can other people mute yourself? I'm getting too much noise, please mute. And this is our last COVID protocol published in July, 6th July, with all the latest information. And I'm going to update 2 of my books, and I hope that in next 2 weeks we'll get the books in our hand and we will be able to provide this to you. So with this, I am inviting our today's speaker, Zina Makhija, to start her presentation. So I'm stop sharing now. Dr. Zina Makhiza, please start your presentation.
Thank you for the very kind words, ma'am. I'm just sharing my screen now. So today's topic is the management and how to diagnose low cardiac output syndrome after congenital cardiac surgery. It is a very daunting complication if it occurs after congenital cardiac surgery. So today's presentation is actually very important since it can occur in any case, even a case as small as ASD repair. So the incidence of low cardiac output syndrome is almost as high as 25%. That means that in about 1/4 of cases that you operate, it is possible that the child will develop low cardiac output syndrome. It can also be secondary to acute myocarditis or septic shock if the child preoperatively was admitted in a bad condition and had sepsis prior to surgery. So regardless of etiology, how do we see low cardiac output syndrome manifest in a child? So the child will be in shock. He or she will have inadequate organ perfusion. So you can see the capillary refill time will be very prolonged. There could be even peripheral and central cyanosis. If it gets advanced, in case it is not treated properly or the child does not respond to the measures you have instituted for managing low cardiac output syndrome, the child can develop organ dysfunction. So then you will see the manifestations of those organ dysfunction. For example, if the kidneys get affected, then you will see renal failure. If the ventilation gets affected, you will see respiratory failure, and that you can pick up from the ABGs and the lactates and the hypercarbia, which will be there in the ABG samples. And generally, there is a post-operative decrease in cardiac index. The SVR or systemic vascular resistance is increased, and even the pulmonary vascular resistance is increased. So it's like a double whammy. And all this leads to a decreased cardiac output, which will lead to multi-organ failure and ultimately the mortality in this case. So when does low cardiac output syndrome occur? Generally, it's early onset. You can see it as early as within 6 to 18 hours after surgery. So it is very important that you pick up this early after this complication early or soon after the child has been operated. So it's very important that post-operative day 0 is the child is monitored very carefully, even if the surgical time, aortic cross-clamp time, and CPB time was very less. Because if you pick it up early, you anticipate it early and you treat it early, there is a better chance that the child will respond to it, and that will decrease your complications which are going to occur as a result of low cardiac output syndrome. My slide is not moving. I don't know. So what leads to a low cardiac output syndrome? One is it's a known effect of exposure to simply cardiopulmonary bypass, because that leads to triggering of an inflammatory cascade due to which many cytokine and interleukin mediators are released in the bloodstream. And these lead to dilatation of the capillaries at the end arteriolar level, which will lead to extravasation of the fluids. And these inflammatory cascades, once there is a lot of third spacing of the fluid and there is decreased return of the blood and the fluid back to the heart, that will be decreased preload. Plus the cytokines and interleukins are going to affect your myocardium, which will be manifesting as what we call as myocardial stunning. That can be secondary to prolonged aortic cross-clamp time also, and giving cardioplegia for a long time also. So now your preload is affected, your myocardium is affected, and there are other things which are happening during the time that the child is on pump. As surgeons, we are using hypothermia in most of the cases. Then when you come off the bypass, there is reperfusion injury because the child is again perfused with warm blood. You are rewarming him. Then these are the things which can happen inside the OT, which can possibly lead to development of low cardiac output syndrome. That is why, as a surgeon, one must be very careful about the cardiopulmonary bypass time and aortic cross-clamp time. So prolongation of these times definitely is contributing to low cardiac output syndrome developing post-operatively in the ICU. Then there can be other reasons also. For example, if there is a residual cardiac defect remaining, the most common example of which is if a residual VSD remains in a TOF repair that is tolerated very badly by the child. So this is one of the most common examples. Then there can be other complex cases where if you leave an ASD, that might not be tolerated well, and that can lead to significant diversion of the blood flow from one side of the heart to another, and can lead to development of a low cardiac output syndrome. This low cardiac output syndrome then has a significant contribution to post-operative morbidity and mortality. So the diagnosis is the key. As I said earlier also, we have to anticipate that whether this child is going to develop low cardiac output syndrome or not. How do we pick it up clinically? The child will have a higher heart rate as compared to normal. So this tachycardia will be persistent. It will not just be short, like, when you are shifting the child from OT and a little bit of sedation is lessened, then also the child develops tachycardia, but this one will be different. It will be persistent. It will be there irrespective of fever, irrespective of complete sedation and paralysis. The child will have low blood pressure. Slowly the urine output will start going down, and you will see the features of poor peripheral perfusion, for example, prolonged CRTs, irrespective of rewarming the child, putting the child in blankets. And there might be some sort of cyanosis also peripherally and centrally. So what are the initial investigations that we do to pick up whether the child has actually developed low cardiac output syndrome? One is regular ABGs. So as a protocol, we do one ABG after shifting the child, one after 1 hour, the next one after 2 hours, and then fourth hardly we do ABGs. But so in these ABGs, they progressively show you that there is increasing metabolic acidosis, increased lactate levels, along with the clinical signs, as I've mentioned before, that is tachycardia, low blood pressure, low urine output, and poor peripheral perfusion. Then you need to be concerned whether the child is going into low cardiac output syndrome. Another very important way to pick up is take a sample from your central venous line and you have an idea of mixed venous oxygen saturation. Normally it should be 65 to 70%, but if it is lower, that means the organs are trying very hard to extract more oxygen and they're sending less oxygen in the venous blood back to the heart for purification. So that again means there is an imbalance between oxygen supply, the oxygen demand, and the oxygen supply. So there is a low cardiac output, it might develop. Then we always prefer to do an echo after shifting the child, and echo can be very helpful as it will help you to pick up one, residual defects which are remaining, which should not be there after surgical repair. Secondly, it will help you comment on the state of the LV and RV contractility. It can help you see the filling of those chambers, whether they are empty, whether it's more preload that is required. It can also help you in picking up the paradoxical septal motion. That will again give you an idea. There are many other things you can pick up depending upon the lesion you have repaired, and they can point you in a direction whether it's a case of low cardiac output syndrome or something else. So as I said, this is the most important slide in the whole of this presentation and the most important aspect of the management. You have to balance oxygen delivery and oxygen consumption. This is the basic principle of management of low cardiac output syndrome. So we have already discussed the possible causes in a broad way. So what now we have to start ruling out significant things. For example, is your airway adequate? Is the ventilation adequate? So you have to check whether the tube is in the right position. You have to check the post-operative chest X-ray to see if there is any fluid there in the lungs, if there is any, pleural effusion. Are there any signs of pericardial tamponade? Is there a broadening of the, cardiothoracic index? Then you have to check the ventilation, whether you are giving adequate PEEP, whether you are giving adequate tidal volume, is the FiO2 okay, is the inspiratory-expiratory ratio okay, and then the pH is very important thing. If pH is pulmonary arterial hypertensive crisis, which is a very common thing routinely encountered in lesions after shifting the patient to the ICU, if that is not managed well, it can further push the child into low cardiac output syndrome. If there are arrhythmias happening, then arrhythmias can also lead to low cardiac output syndrome because the AV synchrony is disturbed. If the AV synchrony is disturbed and your atria and ventricular are not working in tandem as they should supposed to be, the stroke volume will be less and the cardiac output is going to get decreased and the cardiac index is going to get decreased. So that will again lead to low cardiac output syndrome and poor perfusion of the other organ systems. Then we have already discussed significant residual lesions, which a surgeon definitely should rule out to see if the child needs to be taken back to the OT and the repair needs to be done. And sometimes even electrolyte abnormalities, like something you think is very harmless, like hypocalcemia, it can even lead to low cardiac output syndrome. Children as such sequester more calcium into their mitochondria because of the way the endoplasmic reticulum in their mitochondria is structured. It is different from the adults. So their requirement of calcium is more. So that is why you see many ICUs, they start them on calcium drips. Now, if the calcium is less, it can lead to myocardial stunning. And if your myocardium is not functioning well, that means its lucitropic action is affected, which means the heart simply cannot generate, adequate cardiac output. So you have to take care that you make sure that every ABG you are seeing, you see the sodium, potassium, and calcium levels also, and you see that they're adequately supplemented. They should not be ignored. Sorry, I missed a slide in between. So how do we now quantify preload? One is if you have a central line in place, which is usually there, you can see the right atrial pressure and the left atrial pressure. The filling pressures will give you an idea whether your ventricles and atria are underfilled or overfilled. Now, the preload can also be decreased. Suppose if you have rewarmed the child too soon, it will lead to venodilatation, which will increase the venous capacitance, and that will decrease the preload or the return of adequate blood to the heart, which is required to keep it pumping for an adequate stroke volume to be generated. Sometimes, in fact, even inotropic drugs which are started, they can also lead to this dilatation, like for example, GTN and NTG, and by increasing venous capacitance, it will again decrease the preload. Then positive pressure ventilation, if the positive pressure is too much, that will also decrease the RV preload. So we need to make sure that the PEEP that we are giving to the child is not too much. And how do we see afterload? So if you want that the child should have adequate cardiac output, it is understandable that the afterload has to be decreased. That means you have to decrease the systemic vascular resistance so that there is less obstruction for the blood, in simple terms, flowing out of the heart. Now, the reduction in the LV afterload has to be done keeping in mind that there should be at least adequate diastolic filling pressure so that your coronaries are not compromised. Because coronaries, as we all know, need a certain diastolic pressure for filling, so the heart perfusion is not compromised. Now, there are some vasodilators which we know that decrease LV afterload. We know the most common ones used are GTN and NTG. The long-acting ones are phenoxybenzamine. Some surgeons even prefer to put them in the pump blood actually before starting the surgery in very high-risk cases. And then positive pressure ventilation, if you decrease the PEEP, that will decrease the afterload. Now, how to manage pulmonary artery hypertensive crisis. Now, this is the Bible for that. So you have to optimally sedate the child. There should be adequate neuromuscular blockade. So whatever you're using, atracurium or something else, you should make sure that that is done, especially if the child is at very high risk, for example, in TA-PVC cases or in some cases of switches. Then you can actually alter your blood composition to generate a respiratory or metabolic alkalosis, because respiratory or metabolic alkalosis will dilate the pulmonary arteries. That will allow more pulmonary blood flow, that will allow them to accommodate more blood so that the pressure in the pH will decrease. Then you can give more FiO2s. You can actually put the children on almost 100% FiO2s if you want through your ventilator. And you should avoid or ablate any stimuli which can cause a crisis. For example, frequent airway suctioning is anyways not advised in children who are at risk of frequent pH crisis. But in case you think the airway suction is important, just make sure you adequately sedate the child. You can give fentanyl, you can, a good dose of fentanyl or Midas. And then suppose if the child is again and again having pH and it is not manageable with the other inotropes you've started, for example, you might have put the child on milrinone or inoximone, then you can even start nitric oxide. So nitric oxide, it is an endogenous vasodilator supposed to be produced by our endothelial cells, we are just supplementing that externally, and it works on cyclic guano monophosphate. It alters the levels of that in such a way that the pulmonary end arterioles are dilated. But there is a side effect to this, that once you stop the NO, there is a risk of rebound pH. So NO is always tapered off in such a fashion that you clinically monitor the child so that there are no incidences of rebound pH after stopping nitric oxide. This slide is important. Now it's more of a, like a conceptual slide, but if we understand these 4 concepts, then we know how to play around with the various inotropes that we have. And once we know how to use those inotropes, we can actually understand as to how we can alter the systolic and diastolic dysfunction. So these 4 concepts: chronotropy, that is altering the heart rate; then inotropy, which means you are increasing the force of myocardial contraction, which is unrelated to altering preload or afterload. Then dromotropy, you increase the speed of electrical conduction. You make sure the AV are beating in synchrony. And lucitropy, which means you increase the effectiveness of active diastolic relaxation. So if we know that what is the problem, which part of the heart is giving us the problem, then we can use inotropes accordingly, and we can control the systolic and diastolic dysfunction so that we can help the child who is in low cardiac output syndrome. Now, this slide just tells you about the list of inotropes we have. So I can tell you which receptors these ones act on. Broadly, like dobutamine, it acts on beta 1, then beta 2, both. It is inotrope, chronotrope, dromotrope, and vasodilator as well. So everyone has to go home and they have to read about these inotropes. It's very difficult to cover them all in this class and their effects, so that we know which of these inotropes we have to use in our situation. Dobutamine, dopamine, adrenaline, norad. So these are usually the vasoconstrictors that we use mostly. Milrinone is like for decreasing the PVRI. This is very broad classification I'm telling you, but they have other effects also. Then you have vasopressin and levosimendan, which is relatively new. And it is inotropic, lucitropic, and vasodilator as well. So that's also being used very much right nowadays. Then in children, thyroid hormone also is very important. Thyroid hormone is not only responsible for cellular metabolism and hemodynamic stability, it is also responsible for synthesis of contractile proteins. So that ways it has a direct effect on myocardial contractility. Now, once the child is on cardiopulmonary bypass, that itself leads to suppression of thyroxine levels. Now, this suppression, you can see it within as early as 12 to 48 hours after surgery, and it can persist up to 7 days. So it is very important that you can supplement the child with thyroxine in case you suspect that is what is happening, because that will help the myocardium functioning well. This is another important drug, nesiritide, because ventricular myocardium's response to stretch itself is to produce increased amounts of BNP. So BNP leads to natriuresis, diuresis, and smooth muscle relaxation. So that will help it to pump more effectively. So what it does is, if you give the child nesiritide, it will decrease the afterload and increase the preload. So that will again help with low cardiac output syndrome. Now, there are some non-pharmacological measures also you can take. For example, you can delay your sternal closure if you think that the child will benefit from it. But then there are both pros and cons of it. For example, the pros are that it will allow your heart to recover. There will be less edema, and there is no development of a dry tamponade. Whereas the disadvantages of leaving the sternum open, of course, that you are predisposing your child to an increased risk of mediastinitis. Then repeated iodine, preps around that open wound or dressing can lead to thyroid suppression. And once the sternal closure itself is done, after leaving it open, the child may develop some hemodynamic and respiratory changes secondary to the sternal closure. So we have to weigh as to whether the child will really benefit from delayed sternal closure or not. Then you can also induce hypothermia in your ICU, because inducing the hypothermia can decrease the basal metabolic oxygen demand. It will decrease the heart rate. It will decrease the systemic vascular resistance. So that will help in maintaining the mean arterial pressure and stroke volume. But again, if you're inducing hypothermia, it will alter the pharmacokinetics of many drugs. It can predispose the child to sepsis and coagulation disorders. And if your child is shivering, then obviously you need to prevent that by maintaining consistent neuromuscular paralysis, which itself can have its own effects. Because if you're not letting the child move, that sometimes contributes 5 to 10 mmHg to active mean arterial pressure. So you will be losing that component there. Then we did talk about arrhythmias. As if the arrhythmias are there, they can push your child into a low cardiac output syndrome. Arrhythmias are very common, as frequent as 25 to 40% children with congenital cardiac surgery experience one or another arrhythmia in the ICU. So the ones we are majorly concerned with are those which will lead to loss of AV synchrony or will lead to extreme variations in the heart rate. So we have to manage them with proper arrhythmogenic, anti-arrhythmogenic drugs. So because they affect the preload and the stroke volume. And we both now know from the previous slides that preload and stroke volume are very important components of low cardiac output syndrome. Then as a last resort, if nothing is working, you can always resort to ECMO. Now there are, you have options in this. You can have veno-arterial ECMO, you can have LVAD or RVAD. That depends on the kind of case you are dealing with. So what is the advantage of ECMO is that it will allow the myocardial recovery while preventing damage to other organs. So while you are supporting your heart and lungs with this external perfusion or ventilation, what will happen is the other organs are getting perfused properly, so they will be preserved. But the most common complication is bleeding. And many cases it has been seen that the ECMO had to be withdrawn because the child developed intracranial hemorrhage. And again, the cost issues are important parameters in our country because ECMO is very costly. So suppose you have the child is now in low cardiac output syndrome and you are doing everything you can to manage it. Now, prolonged low cardiac output syndrome, you will, but what kind of child you will have in your hand in the ICU? The child will be ventilator dependent. The child will obviously be edematous because of third spacing of fluid, and the child will be malnourished. So what it can lead to is it can lead to difficulties in maintaining sedation. It can lead to difficulties in maintaining a proper airway. And obviously, if the child is swollen, we will have problems having vascular access. And we obviously have to change the lines regularly to prevent sepsis. So that is why it's very important that we are able to minimize the consequences of low cardiac output syndrome. Now, these consequences include renal failure, which is very common because there is poor renal perfusion due to low blood pressure. So diuretics can help, but diuretics are not that much helpful as is peritoneal dialysis, because peritoneal dialysis will help you deal with edema. It will help prevent giving extra fluid boluses, which you will require if you are using only diuretics. If you are using peritoneal dialysis, you may not need to escalate your inotropes, and you can also prevent furosemide toxicity because you will not need to go up or increase your doses of Lasix, etc. Because peritoneal dialysis will help you maintain the balance. Then respiratory failure can occur in these kids. It can be multifactorial. It can be because of fluid overload, malnutrition, muscle weakness, atelectasis, airway edema, or intrinsic lung disease, which is often seen in these children because of the component of PAH. Then because of sternotomy, anyways, we know that functional residual capacity is decreased. So it is very important we manage the ventilator properly. One is the mode should be right. The amount of PEEP you are giving should be right. The tidal volume, we say it should be between 6 to 8 ml per kg, and try to avoid paralysis, persistent paralysis in such a child. Then nutrition is another important aspect that we should not ignore while dealing with low cardiac output syndrome. So it is actually quite difficult because of fluid restriction and gut failure. So it's very important that after 2 to 3 days or 24 to 48 hours, you should try to start a little bit early enteral nutrition, but obviously clinically, first you should watch for signs of GI activity by auscultating with a stethoscope. And you should prefer jejunal feeding strategies to TPN because TPN comes with its own set of complications. And peritoneal dialysis is helpful because it helps to make space for increased caloric intake. So this is like just a broad algorithm, which is how to deal with low cardiac output syndrome. First of all, focus on excluding a specific problem which is leading to it, whether it's airway ventilation, whether it's pericardial tamponade, whether it's pH, whether it's a residual lesion or electrolyte abnormality. Then as clinicians, we should evaluate and treat the specific problem. You can do an ECG, you can also do an atrial ECG to see whether it's the AV synchrony is affected or what kind of arrhythmia it is. And then the medical or surgical intervention should be in lines with what is required to be done. Now, as we have already discussed, for preload clinical exam, left atrial pressure, RA pressure, you can give a fluid challenge of 5 to 10 ml per kg and see if the child responds to it. If the child responds and the pressure increases and the heart rate comes down a little bit, then that means the preload is the issue. Whether you need to transfuse blood. So if it's the child is cyanotic and the hemoglobin is less than 12 to 14, then we transfuse. And if the child is acyanotic, then less than 10 to 12, we will transfuse. And then obviously we have to optimize ventilation because your PEEP is very much, it governs both RV afterload and RV preload. Then LV afterload or RV afterload, you have various strategies to deal with it. For example, short or long acting vasodilators, inodilators, positive pressure ventilation and sedation will help with decreasing LV afterload. Whereas high FiO2, nitric oxide and optimal PEEP will help to decrease the RV afterload. Then inotropes we have already discussed. What inotrope you choose, that is up to you. But the main important thing is that we want to include lucitropy or diastolic function. We want to increase the preload and we make sure that the atrial kick is good enough to push the ventricles to eject enough blood in the form of stroke volume out. So the last 3 slides were quite a repetition, but that is how we broadly deal with low cardiac output syndrome. Thank you very much.
Thank you, Dr. Zina. It was an excellent presentation actually. Many of the students, they joined in last part of your presentation. I don't know why they were late today, but it was a very nice presentation. So I will request you to summarize your presentation in few words like when you suspect low cardiac output state, seeing some clinical feature, then how will you follow the flow chart like your last 3 slides. So for the student, just tell the main points of the flow chart, what to look for and then what to do.
So like as ma'am has said, the last 3 slides are the ones which are really important. And
Yes.
I will just share them again.
Yes.
So basically we have to focus on, we have to find out what is the specific problem, whether it's to do with airway, whether it's to do with your heart, whether it's to do with your lungs. So pH, pericard, tamponade, sorry, and whether there is a residual lesion after surgery or is there some electrolyte abnormality. So we have to focus on evaluating and treating the specific problem. We can do an echocardiogram, we can do an ECG with an atrial component, and then we start with medical or surgical intervention, whatever is required. So if we focus on preload, we should do a clinical exam to see whether left atrial pressure, right atrial pressure is adequate. If we are not able to infer anything from this, we can give a fluid challenge of 5 to 10 ml per kg. If the child responds in the sense that the blood pressure picks up or the heart rate comes down, that means the preload is an issue. Then we have to increase the fluid that we are giving to the child. If the child is cyanotic or acyanotic and the hemoglobin levels are less than the ones mentioned in the bracket here, then we can even transfuse blood. And something else that happens to help with the preload is to optimize the ventilation. So we have to check the ventilator also and whether the endotracheal tube is in the right position or not. Then we can use inotropes to improve the systolic or diastolic function of the heart. For example, dobutamine or dopamine, they are our first choice and then they primarily help to make better the systolic function of the heart. You can add low dose adrenaline, increase the dose of adrenaline if that is not helping. Then you can add NORAD or vaso after that. Then milrinone, it helps with diastolic dysfunction. And obviously to increase the atrial kick, we can also connect the child to a pacemaker if we see that there is any arrhythmia or AV synchrony is disturbed. Then we have to decrease the LV afterload or RV afterload. And that we can do by adding some short or long acting vasodilator. We can alter the positive pressure ventilation. There should be an adequate sedation in the child. And if it's the RV afterload, which is the problem, then we increase the oxygen levels or we increase the FiO2, which is being given from the ventilator. You can add nitric oxide if persistent PAH is the problem, and you should optimize the PEEP levels. So these are the basic things broadly that we do. But if there are other things, for example, there is a residual defect, you might have to take the child back for surgery to repair that defect. So these are the basic things, ma'am.
Yes. About the peak and expiratory pressure in the ventilator, We have like in cyanotic cases and in acyanotic cases, how will you manage the peak and expiratory pressure? For our medical ICU, we usually give some higher PEEP in the cyanotic cases, in the acyanotic cases, and lower range in the cyanotic cases. So, what is your guideline, or how do you follow about the cyanotic heart disease cases and about the acyanotic heart disease cases?
Generally, ma'am, after surgery, when the patients are shifted, the PEEP is maintained between 3 to 5. So that is the general, except for the ones with the Glenn or the Fontan, where we keep the PEEP low, especially in the Glenn patients, like it's only 1 or 2 PEEP, so that the child can generate the breathing pressure, and there is scope for flow into the lungs after doing a Glenn or a Fontan. But in other cases, generally it's kept in 3 to 5, but it can be increased 6 to 8, depending upon what we are, depending upon if we think that, that increased PEEP will benefit the child, and the pathology is primarily pulmonary. But generally in low cardiac output syndrome, the PEEP is maintained between 3 to 5 only.
Okay. About your slide on pharmacological agents, can you go back to that slide, please, where you have seen that the 4 types of action of the pharmacological agents?
Yes, ma'am.
I think this one was a very wonderful one. Can you again mention these things for our latecomer students? This slide.
So these are the basic principles by which we decide which inotrope we are going to use. For example, so there are the heart function. There are 4 parameters to measure the function of our heart: chronotropy, inotropy, dromotropy, and lucitropy. Chronotropy is about the heart rate. Inotropy is basically the force of myocardial contraction. Dromotropy is about the speed of electrical conduction, and lucitropy is about the diastolic relaxation. So you have to find out that which parameter of these is affected, and accordingly we'll decide the pharmacological agent, because then that will we want to alter our systolic and diastolic dysfunction in that way. For example, if we think that the myocardial stunning is there, and we have to choose an inotrope which will increase the inotropy of the heart. So we have to increase the force of myocardial contraction, and that is not related to your preload or afterload. So what will be the best agent in that case? It will be something like an adrenaline, noradrenaline, or a vasopressin. Now, suppose you want to increase the heart rate, or you want to alter the chronotropy, then a good agent would be dopamine. If you want to alter dromotropy or increase the speed of electrical conduction, then for that you have to do an ECG also, and you might attach a pacemaker, and you will change the modes, or you might decide to add an agent to alter that, some anti-arrhythmogenic drug also. And lucitropy is something which will increase the effectiveness of active diastolic relaxation. So the agent with which we target this is milrinone and or inoximone, and these days even levosimendan is supposed to help with the lucitropic function of the heart. So that is it.
Yeah, thank you. Is there any question from anyone?
Question. 24.
Why are you not muting yourself? There is too much noise. Is there any question, Mufajjal? Ashfaq? Jannat?
Touch a low output cardiac.
You have to mute yourself, and if you want to ask any question, you can unmute. So, Dr. Zina, who is taking care of your post-operative surgical ICU? Yeah, is this the intensive care specialist or the surgeons?
Ma'am, both are there actually. Surgeon as well, the pediatric cardiac intensivist also. So I am also there, and they are also there.
Oh.
And we have anesthetists on call also, ma'am.
Oh, so it's better now. Previously, we were seeing that surgeons are doing OT whole day, and then again they are coming to the ICU to take care of their patient. Now you have an intensivist and anesthetist, so you can relax a little bit after doing a long surgery or stressful surgery.
Yes, ma'am.
Yeah. But when you are alone, sometimes you are alone in some place, especially in charity missions and in other places.
Yes, ma'am. So there we have to, ma'am, sit and take care. But there the number of cases and the cases they choose to do is also very limited because of
Yeah.
their infrastructure. So we don't do very complex cases there.
Yeah. I just want to ask you about your experience in arterial switch in newborn.
Yes.
In postoperative period, what
Yes.
is the main problems in these newborns with switch after switch operation?
Ma'am, PAH crisis, and the second thing is like many times we have to keep the sternum open. So sepsis becomes an issue. So we are
Oh,
very careful that we close this. We first of all we don't keep the sternum open if not required, and if even if it's open, we try to close it the very next day.
oh, and what about coronary? You reimplant the coronary. We sometimes think that is there any problem like spasm in the new coronary ostium or like occlusion of the ostium? Is that happen in
Ma'am,
after
yes,
surgery?
it has happened with me, but I think the problem was not spasm. The problem was that it had not been put properly, so I had to go back and revise it. Actually, in one case, it has happened with me.
Oh, but it is not that much common complication, right?
No, ma'am.
And what
But
you do if
it is
the
always better that if you have a doubt, like if I had a doubt, it's better to go and revise rather than wait for it to get better. Because it will, the child
yeah, and
will just go
about the
into ventricular fibrillation and then they just arrest.
yes, yes, and then about like older children, 2 month old or 3 month old with TGA, intake septum and regressed left ventricle.
Yes.
What is your personal policy in these cases as a surgeon?
Uh, Ma'am, then we will
Like
measure
if the LB is regressed already.
yes. Ma'am, if we are very sure that it is regressed, then the option is sending.
Yeah, but we see that some of the surgeons
They are doing it.
they
Yeah.
are doing even in 3 months or
Yeah.
I don't know what parameters they see, but
Yeah.
in echo we
Ma'am,
see that
yeah. Even I have heard a lot about that, but the problem is that we should have long-term follow-up also. It should not be that we have operated and the child goes and dies at home.
yeah.
So if we are very sure it has regressed, like if it's borderline, that is different. But if we are very sure it has regressed, then I will not, like I will
Yeah.
not do it at least.
Yeah, and if it is like older children with a large ASD, there is no chance of like closure of the ASD, and LB is regressed in older children. Is in your experience, do you have any history of doing like training of LB by keeping PA bending like this? LB
Ma'am,
training by PA bending.
to be honest, I have seen it with one surgeon, but I have not done it myself, the training in that case. Because if I have had like two cases where the child was 7, 8 year old, one was 3, 4 years old.
Yes.
I did a scanning because I did a CT scan. We evaluated the LV mass, RV
Yeah.
mass, the ratios and everything, and we did a scanning. But I have seen one surgeon who has done that PA banding.
Yeah. Oh, there is no question today. I don't know why they're not asking. This is such an important issue.
Okay.
Do you want to tell anything from your side for the young students, for the juniors who are still in their learning phase, in their learning curve?
Yes, ma'am. I would just tell them that the clinics are the best teaching place. Like, so the hospital is the best place to learn, not the books.
Yes, yes. This is the most important thing. I also tell them that each patient is a book. There is no
Yes.
need to go to the book.
Yes.
Yeah, I can remember in my training time in Saudi Arabia, I had no time actually to look into the book because every time I was so busy, I don't have any time. Then I finished my training of 2 years, and then when I came back to Bangladesh, And then I started like presenting cases or something. So at that time, I need to read book for the reference or to prepare my presentation. So at the time, I was seeing that what I learned, exactly the same things are written in the book. So retrospectively, I found everything in the book. But initially, I learned from the patient. Initially, I learned from my work.
Yes.
And then I found those written in the book. Not that I saw in the book first, and then I learned there. It was all the practical work from the patient's bedside and from the OT and from the, and in my 2 years training time, I was in surgery OT and in the cardiac surgery ward for 6 months. So 1/4 of my training was in the cardiac surgery department and in the cardiac surgery ICU, because if you don't know the surgery, then, and if you don't know the outcome of these surgeries, what to look in echo, what to see in the echo, then it is actually very difficult.
Yes.
So I think there is a question now. I can check now, and you can see also. One Talukdar Saima, she is asking how long we will continue peritoneal dialysis with low cardiac output state.
It will depend on the case. So till you think the child is edematous, there is a lot of third spacing. Till you think the child's ABGs need to be managed, and you can't manage the electrolytes otherwise by just giving fluids. And till you think, mostly we leave it at least till we have extubated the child. That's very broad, generalization. But mostly we will leave it till after we have extubated the child.
Okay, now I will request our senior doctors here. I saw Santosh Kumar Saha. If he is still here, he can say something if you want. Or Dr. Hannan, I am seeing here. If you want to say something, he can say. Dr. Hannan is a cardiac surgeon.
Okay.
He is mainly adult, but sometimes he do some ASD closures and like VSD closures, simple thing.
Okay, ma'am.
I think there is no more question. So thank you very much, Dr. Zina, for your nice presentation, and keep your presentation like this. I will invite you another day, because this is a very important presentation, very nice presentation, and many of our students missed it today. So I'll again invite you for the same presentation another day.
Yeah, sure, ma'am. And thank you very much for inviting me.
Thank you. Thank you so much.
Thank you.
And take care of yourself and stay safe.
Thank you.
Thank you. Thank you, everyone.